Good morning, everyone. If you could, we're going to be using poll everywhere for this interactive session. So if you guys could get logged in and select that you're able to participate, that will help us with some of our interactions that we have and the questions that we have within the presentation. My name is Dr. Jennifer Monroy. I'm actually one of the allergists here at Washington University. So in the clinic, we see a lot of drug allergies. So I help with, desensitizations, dose challenges, skin testing, and everything for patients with drug allergies, across the gamut from antibiotics to biologics to other chemotherapeutic agents. So I'm going to talk a little bit today about drug allergy, and in particular, focusing on penicillin and cephalosporins, where we have the best data. So I'm going to remind everyone just to go ahead and get logged into Poll Everywhere and select yes, so that you can participate in this interactive session. Okay. Maybe have a few more trickling in. Okay, we're going to go ahead and get started. So in the outline of my talk, I'm going to discuss a little bit, excuse me, of drug allergy, but the definition, epidemiology, kind of the impact of the cost of drug allergy, immune mechanisms, go a little bit further into penicillin and cephalosporin allergy, testing for drug allergies, dose challenges, different beta-lactam allergy pathways that are out there to help mitigate overreporting of penicillin allergy, and also drug desensitizations. So with our first question is actually a question that I'm putting out to the group is, do you actually have a drug allergy? Does anybody have a drug allergy that they have as part of their medical history, whether it be penicillin, amoxicillin, sulfa, and other drugs, or no drug allergy? Which is good. So 15% of our group having penicillin or sulfa, and the 15% is probably pretty similar to what you see in patients that are presenting to hospitals. I myself am like a sulfa drug. I guess I had a rash when I was a child, and I really don't feel like I have it, but I've not had a need to receive sulfa. So drug allergy definition is a hypersensitivity type of adverse drug reaction, or ADR. So these are going to be classified into predictable and unpredictable. So the predictable are dose dependent, related to the pharmacokinetics of the drug, hypotension related to taking a beta blocker. Unpredictable are the ones that are dose independent and are going to be unrelated to the pharmacokinetics. And that's where the drug allergy or drug hypersensitivity is going to rest. Hypersensitivity is going to be objectively reproducible symptoms or signs initiated by an exposure to a defined stimulus at a dose tolerated by normal persons. And within hypersensitivity reactions, these are initiated by specific immunologic mechanisms. So there are multiple types of adverse drug reactions. Now there's all the way up to like type F, but with type A, that's going to be the predictable, as you can see there within that table. Type B being unpredictable, drug intolerance, idiosyncratic drug hypersensitivity reactions. So within the immunologic, you have IgE mediated. These are going to be ones that are very quick in onset, usually within an hour. Sometimes it may be a few hours, but they are very quick onset after encountering the antigen, encountering the allergen. T cell mediated are more along the delayed route. And so a lot of times this is presenting with a rash that's 4 or 5 days after being on the antibiotic. There are non-immunologic. They are direct mast cell activation, and this is what you're going to see when patients come in with reactions to radiocontrast media. It acts very similarly to an IgE-mediated response, but they're able to do that without involving the IgE molecule itself. So epidemiology of these adverse drug reactions, just in general, people coming in with an adverse drug reaction, that's 3 to 6% of all hospital admissions and can occur in 10 to 15% of hospitalized patients. Cutaneous reactions are going to be the most common that are seen, with the incidence of 2.26 per 1,000 person. This is going to increase in older adults. And when you tend to look at poor outcomes with severe allergic drug reactions. Those that are male and actually have cardiovascular disease increases their risk of having a worse outcome. Deaths from adverse drug reactions do occur in about 0.2% to 0.4% of hospitalized patients. So having a drug reaction, drug hypersensitivity reaction, when they looked at the prevalence, this was within Brigham and Women's and also at Mass Gen, and they looked in their electronic health records from a 13-year period, and they saw when going through and actually teasing out that really the prevalence was probably about 13.8%. And you could see that over half of those reactions were going to be immediate, in which 10% of those were anaphylaxis, and delayed were 46%. And if you look, penicillins accounted for a third of those immediate reactions, and almost 40% of those delayed. The incidence of anaphylaxis is estimated to be about 50 to 100 cases per 100,000 person years, and anaphylaxis-related deaths in the United States are due to medications in 58.8% of the time. This was in about 2,500 patients that had been reported. When you look at, there is a difference though in between adults and children. In children, anaphylactic deaths are more related to foods rather than in adults. So having an allergic reaction does, adverse drug reaction does cost about $4.2 billion each year. Most of the time with having a cutaneous reaction, itching hives, it's estimated about 274 per episode. Sometimes they end up going to their doctor's office, go to urgent care. If they do require hospitalization though for cutaneous symptoms such as hives, that cost can increase up to $6,200. Presenting with anaphylaxis into the ED is like a $1,700 event, but if it goes and you're hospitalized, you could see that increases up to $95,000 to $14,000. But on the flip side, there is a cost of having overreporting of allergies. So self-reported drug allergies, there's been multiple studies that have come out that show broader spectrum antibiotics lead to less effective treatment, more toxic effects, and they cost more. The big study that came from Macy that looked at this was in Kaiser Permanente group that, patients that had a penicillin allergy had longer hospital stays, and you could see it's longer for females versus males, and then had that increased rate of infection for C. diff, MRSA, and VRE. And looking more recently at 2 tertiary care hospitals out in Pennsylvania, those that had hematologic malignancy, something like a B-cell lymphoma and a beta-lactam allergy, had a longer length of stay. You can see 11 days versus 7.6 days, which is pretty significant. Higher mortality rate at 30 and 180 days, higher 30-day readmission rate, and an increased rate of C. diff. And you can see the hospital costs just from having a beta-lactam allergy was much higher in those that reported that versus those that do not. So it does have an impact on our patient care when you have a self-reported drug allergy. Looking at the different costs, the alternatives that you have for beta-lactams, as you can see, there is a little bit of a price difference. And a lot of times with the antibiotic stewardship, we were trying to avoid having to use aztreonam, trying to get back to using cephalosporins or penicillins to adequately treat an infection. A systematic cost analysis for people with self-reported penicillin allergy showed inpatient cost in total were ranging from $1,100 to $4,200. Extra drug cost inpatient setting was about $600 per patient, and in the outpatient setting, it varied between $14 to $193. So looking into what the immune mechanism of drug allergy, and really kind of rests along the Gale-Coombs. So this is a table of the Gale-Coombs reactions that you have. The type 1s are the ones we really do worry about because those are the IgE mediated, those are the immediate style reactions that occur right after you are given the drug, and concerning because you can have systemic symptoms such as anaphylaxis and death. So the risk for having an IgE-mediated reaction is higher. The mechanism that happens with this, you have to get exposure to the drug first in order for the body to mount this IgE response. Once that's in place, these IgE cells rest on the mast cells, and when you encounter the drug again, that drug molecule will bind to the IgE, which causes cross-linking and activation of the mast cell. Once these mast cells are activated, that will then trigger vascular leakage, bronchospasm, nausea, vomiting, diarrhea. So these mast cells are very important in these allergic drug responses. And you look in type 2, these are immune complexes that you end up seeing, such as immune-mediated thrombocytopenia with medications. Also, type 3 is more of the serum sickness that you get to see. In more days when I end up seeing serum sickness, it's more along the lines of the biologics. I feel like the vast majority of allergic drug responses that we see, though, fall into the type 4 reactions. They are, as you can see, there's various different mechanisms that are related to it, but essentially they result in some sort of skin manifestation, a cutaneous manifestation. And most of the time, these are just going to be like these morbilliforms or macular papular rashes, but can have more severe symptoms, such as presenting with acute generalized erythematous pustulosis, Stevens-Johnson syndrome, or toxic epidermal necrolysis. And those do carry a mortality risk with that. And this also includes DRESS, which is the drug rash eosinophilia with systemic symptoms. So there is a little bit of risk within having type 4 reactions, but you have to monitor carefully, as most patients with type 4 reactions don't have any serious side effects related with it. And you can see that a lot of this involves the T cells, and there's other effector cells that are involved in these pathways. So high molecular weight drugs, just being an allergen itself, they're usually large enough that they can use an immune response without any help. They are large enough that they are able to cross-link with those immunoglobulin E's, or also bind to T cell receptors. Low molecular weight drugs, though, they do need to bind to a carrier protein to help them elicit this immune response. And this is going to be called this hapten carrier complex. And this is something that's very common in drug allergy. It's seen in penicillin allergy. And in some cases, the metabolite of the parent drug creates the immune response because it then binds to the other protein. So the parent drug is called a prohapten. And this is what you see in sulfa antibiotic reactions. And so within the picture that you see here on the left, you see that there's the free drug that then binds to the carrier protein. And a lot of times that's going to be albumin. And that allows it the ability to actually cross-link with those IgEs to then elicit that mast cell response. In the induction phase, they're binding to these B cell receptors to promote this IgE response. And in the table on the right, you can see that there are different um, molecules that you can, there's 4 macromolecules that are complete allergens, multivalent chemicals, so they have repeating structures, succinylcholine's known for that, the haptenation, which is pretty common, and the beta-lactams being a common one associated with that, metabolism to the haptentic form, which is sulfonamides, and then also just direct stimulation of the T cell receptor, not involving this cross-linking related to IgE. And you can see that with different anticonvulsant medications and also with the sulfa drugs. And this is just another picture showing this processing of creating into a hapten, and kind of goes into a little bit of the information with it. And again, with the prohapten, I'll focus a little bit on this PI concept that they have. And with this PI concept that's in C, what happens is the drug itself is able to bind kind of directly into the T cell receptor groove. So the interesting with this is it doesn't need to be primed. You don't have to see the drug before and you're able to create this memory response to it. And because this involves T cells, this is what you're going to see with more along the lines of these rashes. So it's not going to be associated with having an IgE-mediated response. So clinical symptoms that you present with drug allergy, and signs of anaphylaxis, which is the one we're most concerned with, can vary. Swelling of the conjunctiva, running nose, swelling of the lips. You could have tachycardia, hives, itching, rash, abdominal pain, diarrhea, nausea, vomiting. I have had uterine cramping seen in patients with reactions, the urge to urinate, shortness of breath, wheezing, stridor, and then of course people can become lightheaded. A lot of times they have this impending sense of doom. And you look at patients that have an anaphylactic reaction and they just don't look. You could see it in their eyes that things are not going to go well if you do not do something about it. And when you look at the sign and symptoms of anaphylaxis, the frequency of the occurrence most of the time you're going to see a cutaneous response, and about half the time a respiratory, and then about a third of the time something involving lightheadedness, hypotension, um, as well as about a quarter with abdominal symptoms related to it. With anaphylaxis itself, those that are more related to have a fatal anaphylactic event tend to be is a higher in those that do not present with cutaneous symptoms, because there's a delay in the diagnosis and recognizing that this is an anaphylactic event, and then a delay in the administration of epinephrine. So clinical manifestations of drug allergies, as you can see, it can present in many different ways. And drug rashes are probably what we're going to see the most. And that has a variety of agents that can cause that. Urticaria and angioedema can be related to T cell, but also can be IgE mediated. But these are going to be quick onset with these episodes of hives and swelling, whereas the skin can take days to, these skin rashes can take days to occur. Fixed drug eruptions they're going to be hyperpigmented. They're almost purplish in nature, and they occur in the same site. So as people take that culprit drug again, they will have the exact same symptoms in the exact same spot on their skin. Also, you can have Stephen S. Johnson and toxic epidermal necrolysis. And what involves with that is the oral mucosa. And so that's kind of key. Is when you're starting to get skin blistering, a lot of skin involvement that also involves the oral mucosa, you know you have a more severe type 4 reaction that's ongoing. And you can have fevers, fatigue as well. And there's a variety of different drugs that can trigger that. You get in more with the hematologic, hepatologic, renal. Those are more along the lines of the type 2 responses, anaphylactic being the type 1 response. And then with drug rash, eosinophilia, and with systemic symptoms, you get these cutaneous rashes along with fever, eosinophilia, and then of course you look for kidney involvement, liver involvement, lymph node involvement. There are also other types of drug responses you can get with serum sickness, drug-induced lupus, or even vasculitis. So in the next slide here, I have a few pictures that I want you to kind of just take note of, because I'm going to ask you a question about them. So there are 6 different types of drug reactions that I have shown pictured here. And within the question that I'm going to ask is, what picture will you actually see that's responsible for DRESS? So which one of those is one that you would say this is probably a DRESS reaction? Okay. All right. So it is actually going to be the fourth one, or excuse me, the fifth one that's there. The one that has the very prominent back that is all dark red. Essentially, I'll go over this. The one on the left, the upper left, is a fixed drug eruption. And this was a fixed drug eruption related to penicillin. Now, the one in the middle that you can see close up, that has pustules with it. So that goes along with that acute generalized erythematous pustulosis. And I've seen that myself when I was a resident, really with penicillins. I've actually saw a couple cases actually with Zosyn. The one on the right, because it involves, the upper right, because it involves bullous and a skin involvement, that goes along with Stevens-Johnson. The one in the left lower corner is the typical morbilliform rash that you tend to see related to amoxicillin. And then that one in the middle is actually a redress one. And there can be variations, degrees of the erythema, kind of the redness of the skin. But typically with DRESS tends to occur in more of the in places where they are laying down. So if they're on their back a lot, they're in a hospital bed, you're going to see that in more of the dependent areas, these rashes. And so this is a person that presented with it on their back. And this is definitely a very involved DRESS response. And then the one in the right lower quadrant is actually just your general urticaria and hives that people get. So looking more closely at penicillin drug allergy, what percentage of patients do you think report penicillin allergy can actually tolerate a penicillin after formal evaluation? You have 10%, 30%, 50%, 75%, or 90%. What do you think? Okay, so it is actually going to be 90%. So IgE-mediated reactions occur just in 0.04 to 0.15% of penicillin-treated subjects, and anaphylaxis is actually much lower in penicillin allergic responses nowadays. So it's estimated at 0.01%. Around 8% of individuals, and some studies even say 10%, so a good, let's just say 10% of individuals that are seeking healthcare in the United States report a penicillin allergy. And when you evaluate and look closely into their symptoms that they report, and you're actually able to do skin testing and or a drug challenge, then you're able to really rule out in 90% of patients a sensitivity to penicillin. And part of the reason why this history of penicillin allergy is why it's, I think, still so prominent, and it makes sense kind of with the description that I'm going to go over. So when penicillin was first used in the United States, it was given to this female, and she had beta hemolytic strep sepsis, and she was given 5,000 units IV every 4 hours. And this physician that was treating her, he recalled this back in 1976, and this is what he wrote. He said, "We discussed what to do with the pungent brown-red powder. We decided to dissolve it in saline and pass it through an AK seats, which is an asbestos filter pad, to sterilize it." So needless to say, that does not sound like the body is going to be really welcoming to receive something like that. So really early on, because of the way the manufacturing of penicillin was, it was just a lot more irritating. And the way that we were giving it to individuals also allowed for an increase in immunogenicity. When you look at an immunogenicity of the drug, it tends to be lower for those that are given orally versus those that are given through the skin or through the IV. And so those that are giving IV or intramuscularly, such as with penicillin, that's going to increase its immunogenicity. So early on in 1943, with soldiers that were treated with penicillin, 16% had urticaria. And by 1946, acute urticaria was seen in 0.5 to 5% of penicillin exposures and described multiple serum sickness-like reactions. It was interesting because the serum sickness-like reactions were actually even starting with joint pains and fevers just a couple of days after initiating on penicillin. In 1956, there was an article that said severe allergic drug reactions from IV penicillin were serum sickness in 1 to 5% of penicillin courses, which is quite a lot at that time. And fatal anaphylaxis was estimated at 100 cases in the United States in 1952. And they even feel that that was even being underreported at that time. So essentially, if somebody was coming in with a rash after penicillin, it got into this like theme where, hey, you are at risk of having a bad allergic reaction. You can have fatal anaphylaxis to this. And so a lot of the physicians in that area will say, okay, if you get a penicillin next time, you may die. And so they'll tell the patients to avoid any future penicillin use. And that mentality had been passed down from generation to generation and even within physicians in their training. And so it's been hard to kind of overcome that stigma that you are going to die from having a rash with penicillin the next time that you see it. And I've had individuals that have come into my clinic that are, 70 or 80 years old and said, "Oh yeah, I received it when I was a kid and I was told if I ever get it again, I was going to die." Or my mom told me if I was ever going to get it again, I was going to die. I've actually had patients tell me that. Um, but penicillin nowadays it's a little bit different, and more what we're getting into issues with is just these rashes. And so the pictures below are just showed like these typical um, maculopapular rashes that you get, and these were with amoxicillin. And most prescribed beta-lactam is going to be the oral amoxicillin or the Moxclav. And these medications, of course, are overprescribed, as you guys are probably well aware, and are used to help treat viral upper respiratory infections. So viral infections just in and of themselves are associated with having hives and rashes on their own. So it gets complicated when you're at an increased risk of developing a rash and hives when you add an antibiotic on board, because it complicates the picture to say, is this truly related to the drug or is this truly related to the underlying infection that you are having? Um, in the Penn State Allergy Department, they actually just reviewed patients that had a history of chronic hives, and they are 3 times more likely to have a penicillin allergy than those in that same cohort that did not report penicillin allergy. And when they then looked at the penicillin allergic patients, those that had the penicillin allergy were 3 times more likely to have chronic urticaria. So there is that association with having a chronic skin issue and this increased incidence of drug allergy. in a French study where they looked at patients with active EBV infections, 34 of them had rashes. And when they looked at the probability to have a rash with patients that had been exposed to a penicillin or not, the incidence actually remained the same. So there wasn't a difference of whether or not they received an antibiotic or not if they were going to have a rash. Similarly, in an Israeli study of 234 children that had acute EBV infection, 70% were actually mistreated with the antibiotics, but there was no difference in the incidence between rash of those with the antibiotics versus those that weren't treated with the antibiotic. In another study looking at 88 children who presented to the emergency department with delayed onset hives or a maculopapular rash that occurred during or after 3 days of completing a beta-lactam therapy course, they were tested for a viral infection, and they were actually just re-challenged to the culprit antibiotic. And you can look for the vast majority of that was Amox or Amoxiclav. And only 6 of those children were oral challenge positive, and none of those were severe reactions. And 54 of those that had the oral challenge negative were actually viral positive testing. So as you can see, if they're re-challenged to somebody that developed with a rash and were given a beta-lactam, only 6% ended up having a reaction after re-challenge. So penicillin itself, it's bactericidal. It disrupts the bacterial cell walls and helps to prevent cross-linking. And what happens is, as it's breaking down, this the major antigenic determinant is this penicilloyl moiety. And so it's formed because penicillin will covalently bind to lysine residues, which is typically in albumin, that allows it to form that drug hapten complex that then elicit the immune response. There are minor antigenic determinants as well that are in the penicillin conjugate. So this is benzyl penicillin, benzyl penicilloate, and benzyl penyloate as well. And so these are the structures, as you can see, of the penicillin, and then the major determinant on the upper right, and then on the bottom were the 2 minor determinants. So the major determinant of penicillin allergy is commercially available for testing. It's the only FDA-approved drug for skin testing. The only skin test available for drug allergy, so that opposite. It was initially approved in 1974, and because it's this penicillin, they're very particular. The FDA is very particular how it has to be manufactured. So there's been a couple of times in which they've lost the manufacturer producing it, and so you could see it in 2000, 2001 they were without, in 2004 to 2009. So this AllerQuest company actually was formed by several allergists kind of getting together saying, we really need to get this and put this back out on the market to help it to be available. And so what it is, we call it PPL. It's this penicillyl polylysine. So it has 12 to 15 of the penicillyl moieties, and they're coupled with the lysine residues, which are then given to the patient to detect an allergic response. And you can see in the right corner, that's how it's prescribed. We keep it refrigerated. It comes out, it's a single-use vial that we use it for. Now, the minor determinants, as I mentioned before, unfortunately aren't really commercially available. Typically, if somebody ends up making it, that they are available, so there's nothing standardized for it. So everything else we kind of talk about in terms of doing skin testing, there's literature published for it, but nothing truly is standardized. We don't have a good negative predictive value or positive predictive value. So when we do testing for penicillin, we actually typically include penicillin G to help kind of cover some of those minor determinants in addition to amoxicillin, given that is a common drug that is prescribed. But as I mentioned before, these are not standardized. So with penicillin skin testing with the major and then all the minor determinants has a negative predictive value of near 100%, which is wonderful. The positive predictive value, though, is about 40 to 100%. If I was talking to my boss yesterday about it, and he's like, yeah, if you end up having a positive penicillin skin test, that puts you in the range of having an allergic reaction to penicillin, probably around like 50%. Testing with the major determinant and only penicillin G, though, you can miss 10 to 20% of those sensitized individuals. So it's nice to try to get those minor determinants if possible, but a lot of times that's just not feasible. So there is this potential for this penicillin skin testing kit to come to market. This AllerQuest, which is that same company that does PrePen, just published a study where they were looking at a kit that has the major determinant, which is that PPL, the minor determinant, which is a mixture that's going to involve penicillin G, penicilloate, and penoate, and then amoxicillin. And what they noticed is that the negative predictive value was 97.9%. So they evaluated 455 patients that had a history of penicillin allergy, and they went through skin testing. 13% had one or more positive test result, and 65% of those positive test results were actually to a minor determinant mixture or amoxicillin alone. And if you look down at the bottom there, it's very interesting. Minor determinant mixture alone was 38.1%, whereas the combination of the minor determinant mixture and amoxicillin was 20%, and then all three were about 24%. Pre-pen only were only 3% of those patients. So when they took the skin test negative patients, they gave them an oral amoxicillin challenge, and 8 of them had developed a potential IgE reaction. And when you look at it, one of them was actually severe, the others were actually quite minor. So this is the penicillin allergy skin test. So we do a histamine control that we actually prick, and you can see in that picture, that's how we kind of prick it. We put the solution on the tip of that little skin test thing, and we actually press it down into the skin, and that's the prick. That's essentially how it is. We do a negative saline control, and our negative saline control does contain a little bit of glycerin in it. And then you get the pre-pen and then also penicillin G. We actually do the penicillin G ourselves. We don't order it from the company because we just buy it in the IV form. So what you do is you put the histamine control on and you put the saline control on, and then you prick the skin to the pre-pen, and you wait 15 minutes. And if you have a result, it's going to look like a mosquito bite. And on the right, I kind of show how what happens is that when you prick, it's able to activate these mast cells, which cause the vasodilation that occurs that allows the wheal and then the leakage of all that fluid and stuff. So you get the wheal up at the front and in the middle, and then the flare outwards. And so that's a picture of those wheal and flares that you see. Once that prick is negative, then you go on and do an intradermal. So you take a small needle, we usually do a 26 gauge, and you fill it up with 0.02 mLs of the drug that you're going to test, and you actually just inject it right underneath the surface, much like getting a PPD, and watch again for that 15 to 20 minutes to see if there is erythema, see if there's an increased swelling, and you compare this to that saline control. And you can see in the picture that they have with the pre-pen and pen gene control, it's funny because I swear they probably put a histamine response on that, because you don't see patients like most of our patients, like I said, 90% don't really have a penicillin allergy. So when we do penicillin testing, it's pretty much all negative. The next step that we do also, once we do the penicillin testing, is we actually give an oral challenge, and we give an amoxicillin challenge. And in our clinic, we actually do 500 milligrams with it. So the safety of penicillin skin testing, they looked at the Mayo Clinic from 1992 to 1991. There were systemic reactions seen in about 2.3% of skin test patients, and accounted for 0.12% of all subjects tested. But in a lot of other studies, they really didn't report any systemic reactions from skin test positive, and that's part of the reason why is we start with the prick. So it's just a small amount that if they start to develop a pretty prominent response, we can easily just wipe it away really quickly and help to stop the response. And then that's why we go in next with the intradermal afterwards, because we know, okay, there's definitely not super sensitive that they're going to get triggered with a minute amount of it. So we give a little bit more of the drug in the intradermal to see if we can elicit a response. So what happens to penicillin hypersensitivity over time? And this is in part why I think 90% of people can actually tolerate it. It's not to say that they didn't have a bad allergic reaction when they received it 20, 30 years ago. They might have. It's just the immune response wanes over time. And when you look at penicillin sensitivity over time, at 5 years, half of penicillin skin test positive patients lost their sensitivity. And then at 10 years, more than 80% lost their skin test positive sensitivity. So it's in our favor for somebody that's been more than 5 years without a reaction, that the likelihood that they're going to even have a response is even lower, even if they really did have an IgE mediated reaction. In patients that have kind of been cleared from their penicillin allergy, about 3%, they've gone back and looked, they saw about 3% with negative penicillin skin testing developed a new penicillin allergy per se, and that just looking at the EHR, which is something that said allergy. It didn't differentiate between if it truly was something that was immune mediated or not, but it just mentioned allergy in following a patient's 5 to 9 years after they had their testing. So a low amount that actually do end up reporting penicillin allergy again after they were delabeled. So my question to you before we move on is, what is the major determinant of penicillin? So the major determinant is actually the penicilloyl, and that's what the prepen is. It's multiple penicilloyl that are bound to lysine, so that we call it the PPL. Benzylpenicillin is the penicillin G that helped to make up one of the minor determinants with it. Moving on to cephalosporin allergies, because, in that beta-lactam group, they're part of the fun. So penicillin and cephalosporins, they do share that beta-lactam ring, but there are some differences. They have this 6-membered sulfur-containing dihydrothizine ring instead of a 5-member thiazolidine ring. And in particular, cephalosporins have these R1 and R2 side chains. These tend to be the more important roles in allergy directed towards cephalosporins. When a cephalosporin is given in the body, the beta-lactam ring opens up and then allows this carbonyl moiety to become this bind to the protein, and then this undergoes fragmentation. So that's why they don't feel the beta-lactam ring plays as big of a role. The side chains actually do survive this fragmentation, and so that's why it's hypothesized it's probably the responsible for sensitization. And the studies that they're able to detect immunoglobulin E responses to cephalosporins, it really is typically in that side chain. Here's just that structure comparison of the penicillins to the cephalosporins that you can see. There are some similarities, but also differences as well. So looking at aminocephalosporins, these are going to be the group that has the highest cross-reactivity to penicillins. And these are the cefaclor, cephalexin, cefadroxil, and they have an R1 side chain that's like identical to ampicillin, but it's similar to amoxicillin. And looking at different studies, they say probably about a 16% cross-reactivity between these first-generation cephalosporin, like these amino cephalosporins and the amino penicillins. Within the penicillin group itself, though, the group that tends to have more cross-reactivity is those that share an R1 side chain. And these group A cephalosporins have these methoxy amino groups as part of their side chain. And so ceftriaxone, cefotaxime, cefotaxime, sorry if I'm not saying that right, and cefepime all have an identical R1 side chain. And they carry an increased risk of having a cross reaction. It's not really, I don't have like exact numbers to kind of like tell you, but there's just theoretically there's that risk that can happen. With ceftazidime, it also has a similar side chain as aztreonam, and thus there's a risk for cross reactivity in somebody that has a ceftazidime allergy with aztreonam. And there's not like a number to put on it, but there's been case reports that have demonstrated those that have an allergy to ceftazidime when they've skin tested to aztreonam, they've been positive to both. So looking overall in the grand scheme of these cross-reactivities, within the penicillins and cephalosporins, particularly those that are not the aminocephalosporins, it's less than 2%. So we're looking at somebody that's getting a 3rd or 4th or 5th generation cephalosporin. Their chances of reacting to somebody with a penicillin allergy is less than 2%. When looking at penicillin allergy in carbapenems, less than 1%, and in monobactams, of course, not seen. And even the cross-reactivity between carbapenems and cephalosporins are going to be about 1%. In a history of immediate reactions to penicillin with a positive skin test to one positive penicillin reagent, they had about 40% that were actually positive to the aminocephalosporins on skin testing. When they gave challenges to these patients to cefuroxime and ceftriaxone, those that are in that group A cephalosporin group, all of them passed without any difficulty, which is reassuring. So skin testing the cephalosporins, like I said, there's not this established negative or positive predictive value. So those that have a negative skin test should undergo a drug challenge to see if there's any clinically significant uh, response to the drug. And so when we evaluate for cephalosporin allergy in our clinic, we actually do testing to the pre-pen, the penicillin G. We actually do ampicillin in our group, but it's kind of reported to use amoxicillin, the suspected cephalosporin, and then cephalosporins with similar side chains. And our cephalosporins that we tend to test to is actually um, to ANSEF, and then we also test to ceftazidime. And you can see here that, like I said, it's not standardized, but there's been a lot of data that's kind of come out to try to allow some guidelines within allergists to say what are going to be these non-irritating doses. And as you can see, you can't just necessarily give the drug full dose. You might be able to do that for a prick, but you might not be able to do that for an intradermal dose because that can be very irritating just in general to controls that are even given the medication. Oh, okay.
So apologies. I just realized that we had a couple of people with their hands up. I'm going to open up the lines for those two people, Leslie and Sandy. Apologies. I didn't see those hands up signs. Sorry about that. The lines are open now, so you can ask your questions. So I'm going to leave those open just in case you're just preparing your questions. And Jen is going to continue her lecture, and then just feel free to sort of butt in.
Okay, so this picture just kind of to get you a sense of what we do as allergists is looking at the different dosing and dilutions that we give to the patients to help them with their skin testing. Okay, so my next question is, which two antibiotics have the same R1 side chain?
The question is cephalosporin and aminocephalosporin. Is cephalosporin and aminocephalosporin?
So yes, the cephalosporin and ampicillin is the correct answer, as they are both the aminopenicillin and aminocephalosporin. Okay, so diagnostic testing, this is just a quick blurb that there is other testing that you can take to kind of help aid in the diagnosis. When I see somebody, we like to get a tryptase level because that would indicate mast cell activation, involvement in a drug response. In more severe kind of like these type 2 type responses, you can look at complement levels as well. Getting a total IgE level is not useful for drug allergy. And there are RAS testing. These are detecting drug-specific IgE antibodies, and their sensitivity is less sensitive than skin testing. And part of the problem is to really know what specifically the IgE is binding to, you got to know what metabolites are immunogenic, and that's hard to know for a lot of our drugs. It's been validated for the major determinant of penicillin, but not for the minor, and it's not really helpful. As allergists, we just don't get it. We just get more bang for our buck with doing the skin testing and a dose challenge to help rule that out. And then a negative RAS testing to a drug does not help to rule out drug allergy. In addition, drug allergies, it's extensive. There are other types of delayed type skin testing that we can do. We tend not to do it as much, but for these are looking at more T-cell mediated responses, such as doing patch testing to help diagnose a culprit in dress, where you put the drug in basically petroleum to get a certain concentration, and you actually just put it on their skin and cover it with this like metal disc, and it stays on their skin for 2 days. And when you take it off, you actually look to see if there's redness underneath to indicate an allergy. And like you said, it's not it can be helpful if it's positive, but it's not necessarily as accurate. So it's not done routinely, even in the allergy field. So what do we do with after we get our skin test results? What do we do? Do we do drug challenges or drug desensitizations? And really, a lot of it with the penicillin, because the skin testing is negative, we do an oral drug challenge. And it really actually is the gold standard in determining an acute penicillin tolerance. Because if you're going to have a bad allergic reaction that's IgE mediated, you're going to see it within that hour. So we have you sit down, take the drug, and we watch you for an hour to see if you have a response. You can follow up with the patient if you need to, if you're concerned for a T cell mediated and anything that's going to be probably clinically significant, they'll develop that rash within 5 days. Caveat though is sometimes you just need to have a higher level of concentration of that drug to elicit more of that T cell response. So it's one of those that you have to do a course of the drug to really see if they develop the rash or not. And in my patients that develop T cell mediated, I actually tell them as long as they're not having any blistering, I have them treat through their course of antibiotic. So penicillin skin testing, what we do is we help to risk stratify. So if somebody has a positive skin test, and they're more likely to have a true IgE mediated reaction. So if we're going to do, we typically just go with a desensitization to help get them on the antibiotic that they need to be on. If we really don't feel like that is an accurate skin test, like I said, it's not completely, we don't, the positive predictive value can be 40 to 100%, you can do a dose challenge. And dose challenges are given in different ways. Because we have such great data on the penicillins, they're usually just given as the full dose. In other studies, you can give a 10% of a dose, watch the patient for 15 minutes if it's IV, 30 minutes if it is oral, and then give the remainder of the dose afterwards to see if they have a reaction. And I personally, when I do drug test dose challenges, I tend to actually divide it up into 3 doses. So I do a 10%, 30%, 60%. And if I feel like they're super, super sensitive, I might even do a 1 to 1,000 dose, 1 to 100 dose, 1 to 10 dose, and then the remainder of the dose. And so you can see with the moxicillin, a meaningful dose to rule out an acute reaction is 250 milligrams in adults and 125 milligrams for children. And then they were just looking at use of amoxicillin, such as in endocarditis prophylaxis and whatnot. There was only 1 case of fatal anaphylaxis that was reported in over 100 million treatment courses in the UK, and none have been reported in the United States. So with antibiotic stewardship or antimicrobial stewardship programs, a lot of hospitals are starting to come out with these programs to kind of help offset this cost of having an overreported penicillin allergy. So going in already, we're already thinking they have a low likelihood of having this allergy. What are ways that we can try to get them on the drug that they need to get on to more accurately treat the disease that they have? And this is the protocol that's there with Mass Gen Hospital. And you can see that they break it down into type 2 to 4 hypersensitivity reactions, but you're not going to be able to challenge. The type 1 reactions, where if you feel that they have these symptoms, you can give a test dose, because like I said, that reaction to that 3rd, 4th, or 5th generation is going to be less than 2%. So you give a test dose of 10%, watch the patient, then give the remaining dose to see if they tolerate it, and thus they can continue on that. And that allows the patient to avoid use with aztreonam or other different antimicrobials that are used in patients with penicillin allergy. If they have a mild reaction, just like a rash that happened with it, it's okay just to give the full dose of these cephalosporins. And if they need to get a penicillin or 1st or 2nd generation cephalosporin, they do a dose challenge. And this protocol is implemented really without the use of even having an allergist. So this can be implemented in hospitals that have no access to an allergist. And that's what's great, because if we're saying that 10% of people coming in have a reported drug allergy, then there's just not enough allergists to go around to even be able to evaluate everybody coming into the hospital for it. And so these testing protocols also get the high risk patients that are going on these larger agent or these more expensive agents, these agents that can be associated with more side effects, as well, to try to flag them to see if we can get them on that better alternative. Then their pathway, they also have one if you reacted to A cephalosporin. And similarly, if you reacted to a first or second generation, it's okay if you give one of the third or fourth fits, as long as those side chains are dissimilar, such as I mentioned, those the group A cephalosporins. If it was a third or fourth generation and they needed to give penicillin or cephalosporin that didn't have the same side chain, you would just do the test dose procedure. It was just a mild reaction, you can give the full dose as well. So it's helpful to kind of help to try to eliminate some of these penicillin allergies that are detracting from the appropriate care. Looking at how this improved the antimicrobial therapy guideline after it was adopted, if you look, it was statistically significant that there was an increase seen in penicillins in first generation cephalosporins, third generation cephalosporins, and fourth generation, with a decrease seen in the aztreonam, fluoroquinolones, and vancomycin. So it worked. And looking to see, is it safe? And when they looked at the reactions that occurred before, after its implementation, there really wasn't any statistically significant reactions that were reported. Most are grade 1 and grade 2, which are going to be really grade 1's, those cutaneous, and grade 2 might involve more, maybe some swelling, maybe some low blood pressure or a cough, whereas more severe is grade 3 and 4, and there were none that were reported. And as you can see, the treatment, most of the time, they were just given some antihistamines or and some steroids. So what do I do with drug desensitization? So protocols vary based on the provider that's doing the test, and what their previous reaction was, and also what the drug we're giving. So it's a lot of variability within these protocols. Typically, when we have somebody do it, we say, hey, let's avoid beta blockers, so that if we did have to look for tachycardia, we're not hampered by a beta blocker preventing that. And also with the use for epinephrine, we don't have to kind of go and look towards trying to get glucagon. When we desensitize, we actually start out usually with the 1 to 1,000 dose, and then we'll increase up. And usually the increases they start out and can be tenfold, and then you get into the larger doses, you tend to double. And most of the time with drug desensitizations, they tend to be 6 steps and higher. You get into this gray area where you're doing anything less than that it's kind of considered more of a dose challenge rather than a desensitization. And so what this desensitization does is provide a temporary tolerance that allows the patient to receive the medications without having a reaction while they're on this course. But the important thing is it can't be interrupted. So if it's interrupted, they can lose that tolerance. And if they subsequently receive that medication, then they can have a reaction again. And if a patient, when we're doing the desensitization, says, oh, I'm getting some itching or may have some hives, that's okay. We usually help to treat through that with giving antihistamines to help with that. And to kind of get a sense of like the mechanism that's going with it, it's all about the affinity of these the drug molecule has towards these IgE receptors. If you have a high IgE receptors, really high affinity for it, it's not going to take very much of that drug to elicit cross-linking and thus activation of the mast cells. So when you do a drug desensitization, where you give that small initial dose, you're hoping to bind those high affinity IgE receptors to help take those out of the system so they can't activate the mast cells. We're already binding it, and it's just inactivating the like kind of that response. It's more like an energic response. And then as you increase the dose, you're starting to bind those that have less affinity and thus require more of the allergen to be present in order to elicit a response. And so that's kind of what you see with that. And like I said, that's all hypothesized. That's like the going hypothesis for it. So when somebody comes in to see me for a penicillin allergy, it's really just usually a 3-hour visit. We have them say, hey, hold your antihistamines or any types of drugs that can interact with the histamine response for 5 days. We have them come in. We do skin testing to pre-pen, penicillin. We do cephalexin and the ceftazidime. We do prick testing. So we start out with prick testing at 1 to 10,000, 1 to 100 and concentrate. So we're at these different dilutions, we're able to kind of help pick up on those that are highly sensitive. And any of the people that I can recall even having a positive skin test to a beta-lactam on prick. It was in perioperative anaphylaxis to cephalexin, and that was what was positive, and with a recent response. It wasn't that it was the reaction was 5 years ago. The reaction occurred 6 months earlier. Then if all that's negative, we follow the intradermal testing at 1 to 100, and then also then to the concentrate level. If that's negative, we give that dose of amoxicillin, monitor them for an hour, and they're good. The interesting thing, though, that we have to kind of tell the patient is I have to try to describe and convey to them T-cell mediated reaction. So I tell them, look, you're not going to die from this reaction. You're not going to have this immediate reaction with hives, throat swelling, can't breathe. But there is a possibility if you do a course of this that you can develop some itching, you can develop rash or hives. And I tell them if that happens, please call me and let me know to see. And we haven't had anybody that's had really any issues with our penicillin testing. I with other drugs, like I said, there's not set um, there's nothing that is actually FDA approved or necessarily standardized, but we do skin testing to help, delineate if they're the likelihood of having a true allergy. So if somebody had a course of Bactrim and they had to, I had a patient, she got intubated. Well, her skin test was positive, but if it was negative, there is a potential that that might not be, but it's a little bit more risky doing a dose challenge on somebody that had just recently been intubated. Um, Compared to somebody that had a reaction that was a rash like 20 years ago. So I've had a person anaphylax on me to a dose challenge to Bactrim, and she was somebody that had developed hives about 5 days into her Bactrim course, which I was already leaning towards this being more of a T cell mediated response. Her skin testing to sulfa was negative, and part of the problem that the sulfa skin testing is because it's a prohaptin. So the drug that I'm injecting in the skin isn't what's necessarily metabolized to form that the immunologic drug molecule. So, and I have had that. So that's why it's so important to do those dose challenges. And sometimes it can be difficult to do the dose challenges in the office because patients don't want to go through something that might cause this reaction if there's not a need. So sometimes I might do skin testing on a patient and say, hey, if you do need this drug, you need it to get treated for this, please come back to see me. We will do the dose challenge, and then you will continue on the medication through the course to help treat the infection that you needed. So. And there is also a National Penicillin Allergy Day, which is September 28th. It's the date that Alexander Fleming discovered penicillin as well. So thanks everybody for attending. The next conference is going to be on the 26th, and then there is a survey that you can actually go to. I'll have my slides available. I had listed out all the references here so you can see that there is a lot that go with it. In addition, I just do have a couple of slides with the sulfa, as that's more commonly seen, but really it's that maculopapular rash that's there for it as well. And so that's all I have.
Great. Thank you very much, Jen. Does anyone have questions? I think we could open it up if any of the attendees have specific questions for Dr. Monroy about penicillin allergies or medication allergies at their hospital.
I'm all ears. You can ask away.
I'm monitoring for any hands up, but I don't see any at the moment. We'll give people a little while to finish the feedback. And also, everybody should be aware, all these slides will be posted, and then eventually, though it may take a little while, recordings will be posted on the Missouri DHSS website. So just stay tuned. And you can always email us at mostewardship@worcester.edu if you have questions that you'd like that you think of or would like answers later, or for additional requests for information. I believe Jen was going to try to find a little card that she was going to send out to give to patients who actually were screened and evaluated to not have a penicillin allergy, because that is one of those challenges to actually get people
consistently off.
having registered penicillin allergies. Apologies for the feedback, by the way. Yeah, I know.
No, it's not your fault.
Well,
No, it's not your fault.
The National
Yeah.
NationalPenicillinAllergyDay.com is where the card's at. You want me to tell you that? Okay. So you can find the card. It's on NationalPenicillinAllergyDay.com. And it's just a little business card that people can have with the patient results, the name, date of birth, and it says, on the above date, I received a penicillin allergy skin test, and the results were either negative, positive, ambiguous, or the other one is said, I received an oral challenge or beta-lactam therapy that you can collect, and then the physician just signs their name there, and that's something that they can keep handy. I myself, whenever I do skin testing, I always give the patient the copy of my skin test results so they can keep that as part of their record so that they can pass that on to their primary care physician or any other physicians that are helping to kind of take care of them. But yeah, the act of delabeling, it's very scary for people to go in and actually say, you're not allergic anymore. But I enjoy doing it. I enjoy clearing drug allergy.